First of all, Susan and the entire HITLAB team, I just want to say thank you so much for including this important topic in today. It's going to be really, really fun to meet these incredible speakers and to hear what they have to say. You know, over the course of today, we're going to hear from some companies who are bringing some important innovations to market. And some of the things that you're going to hear about were born of science. And that means that it took anywhere from 5 to 10 years for those companies to get to this point, because they went through a cycle of discovery, clinical research, regulatory process. And what that means is that the things that are going to make a really big impact tomorrow are in the lab today. Maybe if the right questions are being asked, and maybe if the funding is happening to allow that basic research to exist. Now, when we talk about women's health, what are we talking about? We're not just talking about things that are only women. We're talking about things that are mostly women and that are different in women. And that means there's a lot of questions to be asked, some of which, until this moment in time, were never being paid attention to. So it's with great pleasure I get to introduce you to two women who are setting the agenda, who are asking the questions, and who are doing their best to make sure that those questions get funding at the very earliest stages. So Dr. Garrison and Dr. Tempkin, and from here on in, I'll probably refer to you as Jennifer and Sarah. Thank you so much for joining us today. And I think the first thing that I'd like to do is just have you introduce yourself, explain the institute that you're with, and tell us a little bit about how your careers got you here. So Jennifer, we'll start with you.
Thank you, Anna. And thank you, Susan and Dan and everyone who invited us to be here. This is an amazing audience, and I'm so glad to have the opportunity to talk to you all. So I am actually a research scientist. I'm a PhD scientist. I trained as a neuroscientist, so I didn't start my career thinking about women's health. I have a lab at the Buck Institute for Research on Aging, which is about 20 miles north of San Francisco in Marin County. And I also have appointments at UCSF and at the University of Southern California. Now, my own research lab is really focused around trying to understand the brain's Wi-Fi, so how the brain communicates with the rest of the body and how that changes with age. And about 6 years ago, we got really interested in the brain-ovary axis. Now, at the Buck Institute, we are interested in understanding basic mechanisms of aging as a way to extend human health span, not lifespan. And as it turns out, although females live longer on average than males, they have reduced health span, meaning if they're lucky enough to live to old age, they are going to spend a longer period of their lives in poor health. And to me, that was shocking. And we started a center here at Buck to increase research around this question of why do females have reduced health span and how can we extend it? And it really comes down to the fact that ovaries age faster than the rest of the tissues in a woman's body. So the fact that ovaries are aging faster means that females essentially have reduced health span. And so we started a center and a global consortium. So nonprofit, we're not making companies yet, but we're trying to essentially stimulate research that's at the interface between reproductive biology, which is a mature field, and aging science, longevity science, new research that's at the interface there to try to understand what are the underlying drivers of ovarian aging, not as a way to preserve fertility, although I think that that's probably going to be a side benefit, rather to extend the number of healthy years that a woman has. And this is profound because it's not just about fertility and menopause. That's how a lot of people bookend this conversation, but it's rather that when ovaries aren't working properly at any age, it uncovers different health risks. And so for a teenager, that might mean if her ovaries aren't working properly, issues going through puberty or irregular menstrual cycles. For a woman in her 20s, it might uncover risk for things like PCOS or POI. So it's not just about fertility and menopause. It is truly about health across a woman's life. And so we give away grants to basic scientists to stimulate research in this space, and we build resources to try to help that science move faster and to create bridges between scientists, clinicians, early stage founders, funders, policymakers, anyone who has an interest in the space. I'll stop there. Sorry, I didn't mean to go on a diatribe.
I get excited when you speak, so I was with you the whole way. But let's turn it over to Sarah. Sarah, same question for you. Explain your institute and tell us a little bit about how your career got you here.
That mute button, it's still like gets you every time. So I am the Associate Director for Clinical Research at the NIH Office of Research on Women's Health. And the Office of Research on Women's Health is an office, one of many within the Office of the Director in the NIH, that was created in 1990. So not actually that long ago, with the primary goal at that time of inclusion of women into clinical research that was federally funded. And I think for many people today, it's sort of shocking to think that just really a little more than 30 years ago, that women were routinely excluded, especially women of childbearing age were routinely excluded from clinical research. So, with the life cycle of development of drugs or for other interventions, medical interventions, that means many of those things were never tested on women. And so the role of the office in 1993 became to ensure that the mandate from the NIH Revitalization Act that women be included into clinical research was applied and integrated across the NIH. I personally came into the office in 2021. Years are starting to blur. And specifically to respond to a congressional request that the NIH review its portfolios on women's health research. And I think that was timely for a number of reasons. There were three focused topics that were maternal morbidity and mortality, cervical cancer survival, and I'm so happy that Jennifer you talked about chronic disease, because that was the third of the topics that has really become an important focus of my work in the NIH, is ensuring that chronic conditions that are female specific or disproportionately affect women or present and progress differently in women receive attention across all 27 of the NIH institutes and centers.
Excellent, excellent. Sarah, can you take a moment? I described a little bit that the innovations just don't pop up when they're ready to go to market, and the vital role of basic research. Can you just elaborate a little bit on that cycle so that the innovators in the room have a picture of what they might be radar up for?
Sure, and I think some of this comes from my background as a clinician scientist, because I am a physician by training and an oncologist by training. So nothing that gets applied to humans in the clinic is pulled out of thin air, right? Like, it takes a very long time, as I heard other people mentioning. But the NIH has a very large budget. It's the biggest biomedical research funder in the world. This year, the budget is expected to be $50 billion. And about half of that budget goes towards basic and preclinical research. And so that is, I think, very important to this audience, because when the federal government is investing in basic and preclinical research, then that provides a platform of discovery for people who have interventions that are going to be meaningful to the clinic, that they can use those and apply them to patients and figure out how to best use them to patients. And so that is one of the main roles of the NIH. And historically, the NIH has spent about 10% of its budget on women's health. And so that's important to know. And, we hope that grows, but most of the research that gets funded by the NIH comes in what's called unsolicited, meaning that people send in an idea for research and it's reviewed and the meritorious applications are funded. So the more applications that we receive on a given topic, there is more opportunity for us to fund in a specific area.
Great. I'm going to move to the topic of what are the questions that haven't been asked. So when you see a piece of when you have a chance to fund a project and it's looking at something and you say, wow, this is an area where we really, really need to know more. Just from your experiences, I'd love each of you just to tell us about like one thing that's on your radar, like how the heck did we just not know about this? Jennifer, do you mind starting?
I don't mind at all. I mean, honestly, we don't understand how female bodies work, full stop. I, and we know so little about how to take care of women. For me, I think the most compelling and driving question is what is the underlying mechanism that's driving ovarian aging? Like, why are they aging faster than the rest of the tissues in a woman's body? Why does it happen at all? Right? Human females are odd in terms of our reproductive strategy, and also in terms of the fact that we go through this thing called menopause. In the animal kingdom, it's really rare. So that means to me that it's not a biological imperative. So what is it that sets it in motion? It might be one thing, it might be multiple things, it might be multiple cues and timers. We genuinely don't even understand the most basic things about it. And I think until we have that answer, until we understand what's causing it, we can't intervene. And so everything we're doing now, everything we have available now is a Band-Aid. And they're very important Band-Aids, don't get me wrong. I'm so grateful they exist and are being developed, but I think we can do better. And so for me, it's really about understanding how ovaries work and why they're aging faster than the rest of the tissues of a woman's body.
Wow.
just a little thing.
Sarah, what's on your list? What's on your list of things that we either just don't know enough about or maybe even nothing?
Oh, I mean, I'll add a +1 to what Jennifer just talked about. And I think I just want to make everyone aware that, midlife health and the symptoms of menopause and understanding the basic pathophysiology of menopause is one of the highlights of the White House executive order on women's health that was published in the spring of this year. And so, we are very interested in understanding more about what in menopause is normal, what is not normal, how do we treat those not normal things, which is very difficult to know if we don't even know what's normal and what's not normal. And I'll extend that to some other things, which include pregnancy, right? We don't know very basic pathophysiology around what is the spark that causes somebody to go into labor. So that makes it difficult to intervene in things like preventing preterm labor. In terms of the menstrual cycle, the same thing, and how each one of these things across the female life course influence the course of disease is very different. I mean, I'm so glad that Jennifer brought up this thing about women living longer with disease, and those diseases start at younger ages in women also. So, potentially having PCOS or endometriosis at a younger age influences the disease course and trajectory of a woman as she ages and develops hypertension or cardiovascular disease. And I think it's very important that we understand those things while keeping women, keeping those hypotheses centered around the healthcare needs of women.
Excellent. Quick question, big answer, but quick question. Do you think 100 years from now we'll look back on something that is sort of in medical practice with women today and feel about it the way that we feel about using roaches to bleed people and make them like, is it possible that we're at that sort of primeval a stage today? Jennifer, I saw you nod.
I mean, yes. I think a lot of what we do to women is primitive at best. I have used other words to describe it, but I will refrain from doing that right now. I think that a lot of what we do is the best that we. I don't want to demonize physicians either. I think, physicians are amazing and they're doing the best with what they have. But because we have this complete lack of knowledge, many of the things we do with women's health are really barbaric. I mean, IVF, for example, it's not a very kind thing to do to your body. Trying to diagnose something like endometriosis or PCOS can take 10 years, and all kinds of invasive, sometimes surgical procedures. It's crazy that we can't just have a non-invasive diagnostic marker for something that is so prevalent among the population. I think the way that hormone therapy is administered today, I mean, it's an amazing Band-Aid, don't get me wrong, I love it. However, it hasn't changed since it was introduced. And that's because, you know, we shouldn't get derailed by why that is, but, you know, there's so much opportunity for innovation and just doing some simple things to bring a lot of the treatments that we have for women into the modern world, I think, yes. I hope that we'll be moving past them very soon.
I want to say that was such an excellent answer, but that seems inappropriate. That was a big answer. Thank you. Sarah?
No, I'll agree with that. And I'll just, you know, something I'll point out is like progesterone might be the most widely prescribed medication in the world. I don't know that for sure, but I know lots and lots of women are prescribed progesterone in some form, and we really literally don't know which formulation or which delivery method is the safest. And so I think there are a million questions out there to ask. I think the one thing that I think we'll hopefully look back on, and I'm going to just say something that came up in the last session around stigma, like the fact that women and men in 2024 are still like embarrassed or stigmatized to talk about menstrual cycles. I hope that we find that very shocking in 100 years from now.
Great. Now, this conversation could go on a long time, but I'm going to have to probably wrap it up with this question. So you've got an audience here. You've got an audience here of innovators, investors, regulatory, people who are working on the regulatory side. You've got a really diverse audience. What is like one thing you would hope one of those sectors, it's hard to embrace all of them, but is there a sector in particular that you'd like to address a message to, having really informed us all about some really important work that still needs to be done? I'll actually mix it up a little bit. Sarah, why don't we start with you and then we'll go to Jennifer.
I don't really have a specific sector in mind, but I just want to encourage people to really talk to women, find out what their needs are, and listen to the sector, because what women have been told that they need from the medical establishment might not be exactly what they need. And I think by listening and giving women a platform and centering science around what it is that's important to women, that I think that that's hopefully where we, you know, make a breakthrough to where it's having women get more comprehensive care that is working better for them, so that some of the disability that they, you know, and the morbidity that's experienced across their lives can be reduced.
And Jennifer?
Well, I would address everyone. I think we're at this incredible moment where things are changing, and that's, you know, it's all very positive and it's all going in the right direction. I think that, you know, we are coming from a place where the male body has been biology's baseline for the last 100 years. And so we have a lot of ground to cover. And the lack of data is directly related to the lack of funding. What we fund dictates what we know. And so that's also on the private side. It's not just, you know, that the funding that happens in the public sphere, the NIH and other governmental bodies like that, it drives funding on the private side. And so funding on the private side is just as dire, like less than 4% of R&D budgets at pharma companies, less than 4% of investments is going into women's health. And so I think if you're a funder, this is something you need to pay attention to, because those numbers haven't changed over the last 5 years. And that's concerning because there's a huge market here. But also we have to do the science to generate the IP to make these companies. And so as much as, you know, the policymakers, lots of great things happening on the public side, but it's slow. It's really slow. So think about the funding, what I would say.
Excellent. Excellent. We actually have been given the grace of a little bit of time. And so I get to pick a question from the audience. This is teeing off of something that you said, Jennifer. Where do you draw the line between longevity and quality of life especially as it relates to underserved populations?
Oh, that's a great question. So it's really important to make that distinction that we are not interested in longevity per se, meaning like we're not trying to extend lifespan. There are those in the aging research field who want to, extend lifespan, but that's, from model organism research, we know that we can extend lifespan, lots of model organisms, sometimes 20-fold. But what happens in every single one of those cases is you have the period of time where you're healthy, the period of time at the end of life where you have age-related diseases. And those two periods of time scale when you extend lifespan in model organisms. And so that's a nightmare scenario from my perspective. So we do not want to extend lifespan. We want to extend health span, the number of years you're healthy. So just like square off the curve. And once we solve that problem, then I think we can turn our attention to longevity. So that's a really important distinction. And in terms of underserved populations, I mean, I think women in general are underserved by a mile in terms of the healthcare system. And then minorities within that population are also dramatically underserved. So thinking about equity as we extend healthy longevity is important from a lot of different angles for sure.
Excellent. Excellent. Sarah, do you want to add anything to that?
No, I love the answer. And I also just want to stress that equity is, of course, one of the priorities of the NIH, and making sure that discovery is available to everyone and healthcare interventions are available to everyone. And our office actually runs something called the U3 program, which is called the underserved, understudied, underreported women, to just to support research that explores these intersections of gender, race, and other social factors like geography, so that we can better understand how to deliver healthcare and interventions to everyone.
I love that U3 thing, and I actually participated in it, Sarah. So for those of you who are interested in equity among the women at NIH, you should read that report.
Great. I cannot thank you both enough. That was an amazing, amazing panel. And I think you've given us all a lot to think about. And thank you again, HITLAB, for having us.